Hi, good afternoon, everybody. Thank you very much, Martin. Our second plenary fits perfectly with the first session from today. And the topic is quite unexpected, pandemic preparedness and COVID-19. So this afternoon, my colleague Frode and I will moderate the session, and we have 4 magnificent speakers lined up for you. We split our session in 2 parts. The first part will look at the global evolution of the pandemic and the vaccine development. And for this session, we have 2 speakers, Professor Devi Sridhar and Dr. Gabrielle Breugelmans. I will let Frode introduce the second part of the session before we start.
Thank you very much, Vicky. So this is me, Frode Forland. Welcome also from Oslo to knowns and unknowns out there. It's a great pleasure to be chairing this session together with Vicky Lefevre from ECDC. And the 2 last speakers is then on a more practical view from 2 countries of Europe, one in the north. Tegnell will speak about the Swedish experience, and Francesco Maraglino from the Italian experience. And I'll come back to introducing them a bit more in detail later. So back to you, Vicky.
Thank you, Frode. So we're going to look into how prepared were we and how prepared are we. So the first speaker is Devi Sridhar. She is a professor at the University of Edinburgh Medical School and holds a personal chair in global public health. She is the founding director of the Global Health Governance Program and holds a Wellcome Trust Investigator Award. She has written a book. She has written several books. One of them is called Governing Global Health: Who Runs the World and Why? So, Devi, over to you.
Perfect. Thank you very much for having me and for the introduction. I'm delighted to be here this afternoon and hope in the next 15 minutes to give an idea of where we are in the COVID-19 pandemic and where we're going from a global perspective. So if we come to the first slide, what we can see is that the pandemic is taking off across the world. Every day, new records are being set in terms of the number of cases that we're having, as well as the number of deaths. And while in some countries there's the feeling that perhaps this is wrapping up, that we're nearing the end of the pandemic, globally, we're actually probably still in about chapter 2. There's still quite a long way for this to run. If we come to the next slide, in terms of how has this evolved over the past year, well, we can see first it started in China. Actually, this was known as the Wuhan pneumonia outbreak. 80 to 90% of cases were in China at the start. There were some in East Asia, South Korea, Taiwan, Hong Kong, Singapore, managed to suppress effectively. Then Europe got hit very hard. This is the blue. This was Italy, Spain, the UK, Germany to a certain extent. And then we move into Asia taking off. And these are the populous countries like India, Pakistan, Bangladesh, and North America, the United States, seeing record levels of cases, and South America being Brazil. The surprise here, I think, over time is first how effectively China managed to suppress this virus and actually to use the hammer to bring the numbers low. When this was first emerging, some of the modeling projected that there would be over 100,000 infections a day in China, that 80 to 90% of the population would get it. But they managed to, in that period, January to March, bring it under control through pretty extreme measures. And also Africa, that African countries, of course, this is confirmed cases, which means testing is more limited or maybe not catching them. But we haven't seen the hospitalizations and the deaths yet on par with what has happened in other regions of the world. So if we go to the next slide. So this all started on the 5th of January when a memo was sent out across the world to governments from the World Health Organization. China had reported at 31st of December a new, these cluster of pneumonia-like cases that no one really understood what was causing. At that point in time, we didn't understand if human-to-human transmission was occurring. We didn't understand the transmission mechanism of how people were being infected, who was being infected, the case fatality rate. It was really like looking through the fog. Was this MERS? Was it SARS? We just really didn't know. And at this point, countries had to start preparing or not preparing based on very limited information. And if we come to the next slide, this is in the context of global preparedness across the world and the World Health Organization's role within it. Can we come to the next slide, please? Thank you. So WHO records thousands of events over the past couple years, and actually every month screens approximately 3,000 signals a month. Of those, it follows up on about 300 and investigates 30 per month. And so when people ask, oh, at what point did WHO know this was serious? Did global health security experts know this was serious? The point was actually probably mid to late January. 30th of January is when the WHO declared a public health emergency of international concern. By about mid-January, when Wuhan went into lockdown, this was, the largest lockdown of, tens of millions of people the world had seen for, I guess, forever. There was a sense there was something very serious going on, but there was no point screaming in early January, because at this point there's lots of disease signals being picked up, and you can't, yell for every single one. You lose the world's attention. So I think it was an emerging picture in January where countries are really trying to form their strategies, their policies, try to understand how significant this was with such limited information from the Chinese government at that point. So if we come to the next slide. So how do we stop these kind of events? Where do they come from? So the bulk of these kind of outbreaks come from animals. There's estimated to be over 1 million viruses circulating in the animal kingdom. Largely it's mammals who seem to infect humans. And at some point, some of those viruses manage to make the jump to infect a human. And at some point, some percentage of those will sustain human-to-human transmission. And if they sustain human-to-human transmission with respiratory mechanisms, it becomes very hard to control. And that's one of the things that just happened with SARS-CoV-2. We're still investigating the origins of this, but it looks like coronaviruses are in bats. So that was probably the primary. There might have been an intermediary host. And it just happens. And so we have to, in the future, if we want to stop these kind of events, look at the relationship between animals and humans, whether it's in wet markets, whether it's in factories, in terms of industrial farming, whether it's in deforestation, urbanization. We have to get to the drivers, because we will not stop viruses in the animal kingdom. We can really try to stop the spillover events, because once it spills over, it's very hard to control, as we've seen. So if we go to the next slide. And then we have, of course, the world and how fast this virus moved across because of our air networks. And it's similar to what has happened since 1851, when states first got together to arrange, to agree on the international sanitary conventions. But the virus moves when people move, and people move quicker, faster, and more unexpectedly than ever before. And some of the modeling at the time was trying to understand which areas would be hit harder based on air transport networks. But actually, it wasn't Frankfurt and Amsterdam and London that were hit first. It was actually Iran and northern Italy, ski resorts in Austria. So as much as we try to kind of plan based on air routes, there are also unexpected ways that this virus transmitted through elite networks, business travelers, cruise ships, holidays, that meant that while some of it is predictable, there's still a large element of luck or chance in terms of where actually the hotspots emerge. So we come to the next slide. So I want to just turn to the next part, which is what do we know so far 10 months into this, and what do we still not know? Because some people say, oh, especially as we go into cyclical lockdowns, that we haven't made progress. But I think we've learned a huge amount over 10 months, though we still have questions outstanding. So if we come to the next slide, this just kind of tries to sketch some of the big issues. So on immunity, we now have an antibody test. This took a while to develop, and that can give us seroprevalence, how many people have antibodies. And what we've seen is actually these are remarkably disappointing in most contexts. In Scotland, some of these return in rural areas 1 to 2%, in cities like London, maybe 20%, and very hard hit areas of New York City, maybe 50%. But generally, it means the bulk of the population don't have antibodies being picked up by these tests. On the plus side, we see T cells, another part of the immune system, seem to offer a durable response in those who have had SARS-CoV-2 for about 6 months, which means there could be other parts of the immune system that are responding to this virus. And perhaps there's more people that have been exposed to this and have protection than our seroprevalence studies are revealing. What we don't still know is how long immunity lasts. Is it going to be 6 months, a year, 2 years? We know coronaviruses are notoriously short in their immunity, and we don't really fully understand the extent of population immunity, although we can guess the bulk of people are susceptible because of the transmission networks and how fast this accelerates in different parts of the world. Health issues. We now understand it's not just pneumonia, a respiratory disease. It's it's a multi-system disease affecting all parts of the body. We have long haulers. These are people who seem to be suffering for months from COVID-19, generally young people who don't die, but kind of suffer with kind of flu-like fevers, fatigue. And we know children can also experience an inflammatory disorder 5 to 6 weeks after being exposed, though it's relatively rare. But we don't know how long recovery could take. Is this an autoimmune condition that lasts forever, for a year? And the exact percentage of people who develop this, which is obviously a huge consideration for governments who were modeling off deaths, but maybe we're not modeling off morbidity. Vaccine, great news with new candidates. We have AstraZeneca, Moderna, Pfizer all coming through. We still don't know whether one will provide protection from reinfection, for how long, and whether it'll actually stop further transmission or just reduce symptoms. Treatments, we have 2 approved treatments already for those who are hospitalized. What we really need is a treatment to keep people out of hospital and the burden off health services, because what really gets you with this virus is the health service capacity and the hospitalizations. And that's why governments constantly underestimate it, because it's not about it killing you, it's actually having enough beds and staff and ICU units to be able to treat everyone who needs it. But if you could have a treatment that people could just get, that would be transformative. And finally, children. Children are so puzzling. Younger children seem to be different to older children. They both carry the virus, have similar viral loads, but they transmit to different extents. And we don't fully understand why children are less affected, why we see fewer outbreaks in nurseries and primary schools compared to universities, and the roles of schools and community transmission is highly politicized and debated in the scientific community. From our Scotland experience, I would say primary schools and nurseries play very little role in transmission, secondaries a greater extent. But there are other examples coming out from other parts of the world where scientists might say something different. So there's not consensus. So we come to the next slide. So governments basically had 3 different models they could follow. And these are really archetypes and sketches, all have trade-offs. You had countries that saw this and followed the China model or the New Zealand or Ireland model, because you can just lock down hard, you clear the virus with test and trace, you put strict border measures, and you keep trying to stop imported cases. So kind of elimination, but you're going to have flare-ups, and so you constantly just keep going after those flare-ups, but you try to keep it minimal. East Asia has followed this, Pacific. Islands find it easier, obviously. Then you have a control, the German or South Korea model. You have a voluntary kind of light lockdown, very strong testing and tracing, strict rules over super spreading events where your testing and tracing breaks down, and light border checks, testing people at airports, making sure you have quarantine, but you're not really sealing yourself off the way some of the islands have. And finally, I call the herd immunity or the Sweden model. And I think it'll be interesting to hear, because actually I don't think Sweden actually was doing this, but I think it's become known as the Sweden model in the field, whether it's in British newspapers who referred to the Sweden model or American presidents who referred to the Sweden model. But basically it means try to slowly run this through, similar to kind of the flu, hope for mutations or treatments to make it, less fatal. Try to keep your deaths and disability to a minimum, to keep your health services running, and to keep confidence in the economy so people don't change their behavior. So these are kind of different archetypes, though I think really what most countries are doing is in the middle of control, trying to buy time for some kind of solution. So we come to the next slide. And control model looks like this. It basically means that without protective measures, your health system capacity is going to be breached, and people will die who don't need to die because they're not getting hospital care. And we know with this virus that if you do offer good care, you can get your case fatality rate quite low to 0.5%, 0.6%, but that if people don't get care, they can't get oxygen, it can jump up quite high. So governments put in place these restrictions or measures to stay within that capacity to try to make sure everyone can get the care they need. And this is why we see these lockdown and release cycles happening across Europe. So if we come to the last slide. So countries that were the economic issues. So some countries saw the economy and health and saw we had to make a choice. And I think now looking back 10 months in, we can see that countries that were unable to control their outbreaks have tended to suffer the most economic pain. Britain is an example, if you see in the right-hand corner, Spain as well, where the countries that managed to suppress effectively and without needing long, severe measures, look at Vietnam, China, Taiwan, South Korea, even Finland and Denmark, have tended to do better, both in terms of deaths and in terms of their economies. So next slide. And I think that's wrapping up. Just say everyone wants to know when this will end. And really, this could end in very few ways. There's a piece out, I won't go into it now because that would be a whole nother lecture, that if you'd like to have a look at, where I sketch out how actually could the whole pandemic end. Because in the end, there are very few ways this is going to play out. Hopefully that will be, my preference would be a vaccine, and that we will have that soon in the next few months, because that will be the least loss of life and the quickest way through this. But potentially, if we don't get an effective vaccine rolled out, there are going to be other endings. So I'll stop there after hopefully in time of 15 minutes. Thank you.
Thank you very much, Devi. Yes, you are perfectly in time, and you put out a nice question there for the discussion. So I will certainly bring it back to you. in 15 minutes. In the interest of time, we will not have a discussion now, but we will start the discussion after the second speaker. So Dr. Gabrielle Breugelmans is our second speaker. She is the head of epidemiology at the Coalition for Epidemic Preparedness Innovations. She is an infectious disease epidemiologist with a large expertise in global health, poverty-related disease, access to medicine and vaccinology in low to middle income countries. Her talk will focus on the global perspective on the race to develop a COVID vaccine. Gabrielle, please, the floor is yours.
Great, thank you. Let me see if this is working.
We hear you, we see you. That's
I don't know, maybe you forward the slides? Okay. Okay, maybe thanks Vicky for the introduction, and I am very happy to be presenting here today. And I would like to thank the organizers of the escaide conference for inviting me to talk today about the global perspective on the race to develop a COVID-19 vaccine. I've structured my talk into 3 different sections. First, I would like to talk about CEPI, the ACT Accelerator, and COVAX. Second, I would like to give you an update on progress made to date on the COVID-19 vaccines and the challenges we have encountered. And thirdly, I would briefly like to look what your future holds for us. Next slide, please. So before deep diving into COVID-19, I want to take a step back to highlight CEPI's origins, how we work, and the reason actually for our launch. So the world has had many warnings in the last 20 years, with the emerging of Nipah in Malaysia in 1998, with SARS in 2003, the H1N1 flu pandemic in 2009, we had MERS, we had Zika, and many more. So planning for emerging infectious diseases is especially challenging, since the market potential for vaccines against these diseases is limited, and testing such vaccines in outbreak situations is actually extremely difficult. However, the devastating outbreak of Ebola in West Africa in 2014, which killed more than 11,000 people and had an economic and social burden of more than $53 billion, really showed us that very few vaccines are ready to be used against these threats when there's an outbreak. So CEPI was founded in 2017 by the Wellcome Trust, the Gates Foundation, Norway, India, and the World Economic Forum, as the result of a consensus that a coordinated international and intergovernmental plan was needed to develop and deploy new vaccines to prevent future epidemics. So we are a global public-private partnership, and we were designed to fill a number of critical gaps in the vaccine ecosystem, including to advance vaccines against known threats such as MERS, but also to fund new technologies to rapidly to respond to what we call disease X, the unknown, and to coordinate activities to improve our collective outbreak response. So since the first EPI reports of COVID-19 in early January, we at CEPI have worked around the clock in collaboration with WHO and other partners, really to respond. Since we were already funding MERS vaccines and preparing for disease X, we were actually able to quickly leverage on these initial investments for COVID-19. Next slide, please. So to minimize further loss of life and economic impact caused by COVID-19, so every country in the world needs vaccines, and we really need them fast. So the X Accelerator was launched in April of this year and has raised close to $8 billion. This is really an unprecedented and really represented also a coming together of the global community to address the challenges of a pandemic. So the whole of the Accelerator in its entirety covers diagnostics, which is taken care of by FIND and the Global Fund, and therapeutics, which is coordinated by the Wellcome Trust, the Gates Foundation, and Unitate. However, our focus of CEPI will be on COVAX, which is the vaccine pillar, and we are co-leading this together with Gavi and WHO. So if we get this right, it will ultimately help us to achieve our goals of speed, scale, and access to vaccines for the world. Next slide, please. So before the COVID-19 pandemic hit, really under the business as usual approach, it could really take more than 10 years or more to develop effective vaccines, and years or decades to ensure they would reach everyone in the world. So during the 2009 H1N1 pandemic, effective vaccines were produced only after the epidemic had passed, and therefore, in essence, had relatively little impact in preventing many infections. And furthermore, most of the doses available were actually bought up by high-income countries through bilateral deals with developers, and therefore they never reached the LMICs that did not have enough buying power. So we do know that the demand for COVID-19 vaccines will vastly outstrip supply. And in order to avoid the situation seen back in 2009 with the H1N1 pandemic, CEPI, Gavi, and WHO have partnered through the COVAX initiative to develop, manufacture, and fairly allocate 2 billion doses of COVID-19 vaccine to vulnerable populations by the end of 2021. Next slide, please. So the COVID pillar is quite radical in its ambition, I would say, but very practical in its end-to-end approach. So by combining CEPI's leadership in vaccine development and investments in manufacturing with Gavi's track record in revolutionizing access and delivery, and with WHO technical and scientific expertise, the pillar really builds on a heritage, I would say, of success in promoting global health, and it will have the largest impact on reducing mortality and transmission of COVID-19. So what COVAX does, it pools financial resources to develop vaccines, to purchase them at scale, and investing upfront in manufacturing so that the vaccines are ready to be distributed when they are licensed. So the effort to develop and deploy vaccines goes hand in hand with efforts to enable equitable access to all countries at the same time, regardless of income. So we have now 187 economies that have joined COVAX to have access to doses of vaccines for their populations. And within those 187 countries, there are 92 LMICs for which there's a fundraising for an advanced market commitment to ensure that they also have access to the vaccine at the same time as the high-income countries, really in order to avoid having a small number of countries having access to the majority of the vaccines. Next slide, please. So what's the progress we've made today? I really would say, next slide, please. The progress we've seen so far is really unprecedented, given that the virus sequence is only available in January of this year. So there are currently 330 vaccine candidates in development, and 59 have already reached clinical testing. And normally this would take multiple years to even to get to a phase 1. So there's a very wide range of platforms, including the classic live attenuated and the inactivated platforms, through the more new and innovative platforms such as the mRNA vaccines. So under COVAX, CEPI has developed the largest and most diverse portfolio of vaccines. 9 are under development, of which 8 are currently in clinical trials, and 3 are in late-stage development, including AstraZeneca with Oxford, Moderna, and Novavax. And the objective is, through a coordinated approach, to deliver 2 billion vaccines by the end of 2021. We at CEPI, we are speeding up vaccine development through investing in innovative technologies such as the DNA and the viral vector platforms, but also through, at the same time, in parallel, funding elements of the vaccine development process, and this is at risk, particularly the manufacturing. Next slide, please. Probably most of you are very aware already of this. We have to date seen 4 interim readouts from 4 companies, including of which Moderna and AstraZeneca, as just said, are part of our portfolio. And I would say the interim efficacy data by the different developers is actually very encouraging. Although, and that needs to be noted here as well, we are moving really with unprecedented speed to develop these vaccines. There will be absolutely no compromises on safety. Both the clinical development process and the licensing process for a new COVID-19 vaccine will adhere to the usual strict requirements of independent regulatory authorities, such as the FDA, the EMA, and also the WHO PQ. So in the end of the day, I really think that safety underpins every element of our vaccine development process, regardless of the urgency with which a vaccine is needed. Next slide, please. So in order for COVAX to deliver on its commitment, there's a lot of emphasis on finding the manufacturing of both the drug substance, that means that's the bulk material, and the drug product, so filling the material into the vials. And then there's also the issue of labeling. So the efforts to reach our goal, it's really, in the manufacturing process of vaccine is really, it's a very highly complex activity. We have faced many challenges. There's still many challenges ahead of us, particularly for low resource setting, including manufacturing scale is only happening now, including tech transfers. Usually that takes a long time. Data currently is focusing on the adults and the elderly, but we also need to look at pregnant women. We need to look at pediatric populations. We need to know how well the vaccines work in those situations. For the first wave of the vaccines, 2 doses are likely needed, and we need to find efficient ways to deliver those. With the mRNA vaccines, there are cold chain requirements. They need ultra cold chain -70, -80. As Shiva already mentioned, the production of the vaccine is unknown to date. Maybe there may be a need for a booster, we don't know. And of course, we need to put efforts into pharmacovigilance and really to ensure the monitoring of the safety of the vaccine. And then lastly, the regulatory burden is going to be huge. I mean, having 187 countries in COVAX, that means is every country going to require its own label in its own language. So I think there needs to be some pragmatism from the regulators. I think that's very important. Next slide, please. So what will the future hold for us? Next slide, please. I think this is not the first pandemic of the 21st century, and will certainly not be the last one, as we epidemiologists know. Certainly, COVID has provided us with an opportunity to carefully think about how we can reduce the risk of naturally occurring threats. We see that trends are converging in a way that could make the world better prepared for the next pandemic. There's certainly political will to invest in health security, and hopefully this will be maintained once the pandemic is over. We've seen a revolution in vaccinology with multiple new platforms developed and approved. And I think we've come at a point that there's a global desire to reduce pandemic risk. So in the end, viruses are collective transnational threats, and we should tackle them collaboratively in the future. And some of the building blocks have now been established, and really, I hope that we can build on them in the future. What we need moving forward is a global end-to-end R&D system and financing, very important for preparedness and response. And we really need to rethink how we can systematically reduce the risk of threats. And finally, we really need to recognize that national health security and global health security are interdependent. And with that, I would like to thank you for your attention. Thank you.
Thank you very much, Gabrielle. Now we have time for some questions. I see some questions already coming up from the audience in the chat, and I realize I'm not such a good moderator because I didn't tell you that you could post questions in the chat. So please do that. Go ahead with that. So maybe I can start with a first question for you, Gabrielle. I mean, you already mentioned that there would be some challenges. So assuming we get a safe and effective vaccine in the near future, what are the main challenges, in your opinion, to get this in actually towards the billions of people who need it?
Yeah, thanks, Vicky. It's something we're really thinking about every day in at CEPI, and many of the challenges actually will be very familiar, such as ensuring the quality in the manufacturing of the biological products, with all the demands such as manufacturing entails. I think there are particular challenges that apply to the manufacturing of COVID-19 vaccines. First of all, it's already applied because in order to meet the demand for the billions of doses in a timely manner, we have to start building manufacturing capacity now. That means setting up multiple plans for products that may never be made. Really, we are manufacturing at risk. And then also having an understanding that the supply chains are fragile. This is really sort of a major undertaking, I would say. So CEPI really favors scaling up, making the existing plants bigger, but also scaling out, meaning setting up the plants in multiple locations to ensure that we have the biggest global manufacturing footprint. And we are really looking at local manufacturing capacity right now to look for the essential ingredients of the vaccine, and really to make sure that things are all in place to arrive at the right time to have a final product. Like, for example, we actually earlier this year we set up an agreement with an Italian-based group for the supply of 100 million glass vials to hold up for the 2 million doses of the commitment of COVAX. And usually you don't associate CEPI with buying glass vials for vaccines. You know, there's a major issue with the labeling that I also indicated, and also just the packaging. So getting the actual vaccine product ready is already a major challenge. I think also the procurement, the allocation, and the delivery challenges is also something that we have to overcome in the very short order. And we really, it's a feat that will require really an end-to-end multi-organizational approach. And that's why we are also working very closely with our partners with Gavi and with WHO to really to make this a success.
Thank you very much, Gabrielle. Then I have a question for Devi, because you ended your presentation. When will this crisis end and how will it end? So what are your views on this? I mean, I heard you mentioning a vaccine, but what do we do in the meantime? What scenarios do you see?
Well, I think in the end, and I wrote that piece in April, so it's a little bit outdated, but the 4 ways this could have ended from the start are first through natural infection, that basically we all get it over time because the control measures increase in cost the longer they continue. So at some point, governments might say the cost of controlling this is higher than the cost of letting it go through your population. And so there, without treatments, we would just see mass death and many people getting extremely ill, health systems collapsing. We've seen this already in the Amazon. I mean, some of those communities have seroprevalence over 75%, and it's still accelerating, saying that kind of the herd immunity threshold is probably around 80 to 90%, but that would have been kind of worst case. The second one would have been that we get a treatment. So yes, we have this infection, circulating, but it becomes treatable. And so it becomes something that we just live with treatments. The third is a vaccine. And then eventually we do get this vaccine and it becomes a vaccine preventable disease. And probably what we'll see is, I think what we will see over the next year or two is higher income countries will have more protection, and lower income countries in fragile contexts, which have less access to a vaccine, will take more deaths from this. And finally, and this is the most unrealistic scenario, but we have to put it on the table, is eradication, that actually countries start to follow the island model and say, we don't want to live with this virus. That becomes more realistic if you didn't have a vaccine, if you didn't have a treatment, if you didn't have, if there is a way to control this through mass testing. And so that was just one of the ones. So if we look at kind of the pandemic, there were 4 ways it could play out, and countries were basically buying time through restrictions, through test and trace, through different kind of strategies to get more information to see how far the science would progress before figuring out kind of which of those 4 would we ultimately go for. And I'm most optimistic now that probably we'll end up with a vaccine in the next 6 months to a year.
Thank you very much, Devi. Frode has been following the questions from the chat, so he will now bring some of the questions from the audience.
Yeah, this is from Giri Shankar, and it's to Devi. In the hindsight, what additional early warning signals, both formal and informal, could or should have been considered for better preparedness in Europe when things were unfolding in China and South Asia?
Well, I think, so the 2 things I think, if we look at European countries as well as North American countries where they've done perhaps less well than they could have, was not learning from what was happening in East Asia. So as I mentioned, in China, the early modeling said this was going to affect 80 to 90%. It was uncontrollable. It was like flu-like through respiratory. It's like trying to stop the cold. You just can't stop it. And that every country, the view at the time in January is every country would fall to this. It was just a question of time and of your health services capacity. So what you saw across Europe because of that was, first, many countries pursuing their pandemic flu strategies. So in Britain, we had a 2011 pandemic flu strategy, which basically said you try to keep things open and you're just trying to keep, mitigating the worst effects of this rather than trying to stop infection. You just slow it. And so I think many countries were on that flu approach. And the second thing you saw was the building up of hospitals. So trying to build, so in that line I showed, trying to raise that to mean that you could actually treat more people. So treat your way through this. And I think what we've learned since then is, first of all, that no country could treat their way through this because the amount of people that are susceptible to this and the hospitalization rate, which is why we end up in these reactive lockdowns. And that actually a SARS approach to try to drive down numbers to very low levels is probably optimal, both from a public health, but also from an economic perspective, because you keep confidence in the economy and you can keep most social and economic activity going. And that there are ways to control this virus because it does not spread like flu. It spreads through clusters. Testing and contact tracing can work to control it. And the 3 things, we did a review for the Lancet where we looked at how have countries suppressed this effectively, and we compared countries across the world. And the 3 things countries did, and it actually wasn't about lockdowns, what they really did effectively were, first, having good test, trace, isolate. So getting testing really got in place, getting the tracing going, and also isolation, supporting people and managed isolation to make sure people were isolating and not passing on to others. The second thing they did was really good voluntary guidance to their populations about avoiding crowded spaces, wearing face coverings, washing your hands, telling people to avoid indoor crowded settings where we know this virus just loves to transmit. So not like harsh restrictions, but just awareness of the danger of this virus. And the third thing is border restrictions. I think that's one big missed opportunity for the world, was that those countries that have implemented travel restrictions and border measures to try to catch cases and new strains have done better than those who have tried to stay open. And we've seen this in Scotland because in the summer, we basically eliminated the virus. We had throughout June and July, a handful of cases, positivity near 0%, bulk of tests coming back at negative. But then tourism season hit and many people came in for university studies as well, movement of hundreds of thousands of people. And now we're in our second wave with cases going up, having to go into restrictions. And the sequencing is now showing that a lot of that second wave is attributable, actually the second wave is attributable to newly imported strains. And so actually having checks that once you get your numbers low, how do you sustainably protect low prevalence?
Okay, thank you. That's a hot topic, the border control issue. I think we can come back to that in the discussions. A question for you, Gabrielle. You were saying that there is an aim here to give equitable access to all countries for the vaccines at the same time. How do you see that when you compare the aim of the COVAX compared to what Europe has done for themselves to really get access to these vaccines first? Will it be possible, really, do you think, to get this to all countries at the same time equally?
It's really, thanks for it. It's really our aim, and we've seen also these bilateral deals. But like the aim of the COVAX is 2 billion doses by the end of 2021. Of those, 1 billion doses are for the LMICs, and 1 billion doses for the self-supporting countries that have signed, the high-income countries that have signed up to the COVAX facility. And but really, COVAX is an insurance. So really, by having the demand commitments up front, we can also invest up front to make sure that the doses are becoming available at the same time for the high income countries and the low income countries. And this is also by really working with the developers that they sign up for COVAX. Right now, we already know that AstraZeneca and Oxford, they have already committed to commit 300 million doses to the COVAX facility. We also I think Sanofi and GSK have signed up for 200 million doses, and the Serum Institute. Of course, we want other developers also to sign up for COVAX, including Pfizer and Moderna. And I think those discussions are ongoing. But really, then. With Gavi, there's the COVAX facility, which is the procurement mechanism within the COVAX pillar. Is really that with the advanced market commitments, that there's enough funding available to buy the vaccines for the LMICs, and in the end, also that we can deliver of our commitment of also having 1 billion doses available for the LMICs by the end of 2021.
Thank you. I'll have one last question from the chat and then hand over to Vicky. And this is again for you, Devi. Given the origin of most of new human infections is wildlife exploitation, what in practice should be done to reduce this risk? This is a big question with a very short answer. You have maximum 2 minutes.
I'm an academic. We talk a lot. So I think the key thing is we need to, at a global level, relook at how we look at the animal-human nexus. We have the World Health Organization, but it looks at human health. And then we have the OIE, which looks at animal health. But we don't have good ways of actually regulating across human and animal health, like doctors with vets working together on where infections coming from and kind of spotting them. There have been some experiments for antimicrobial resistance, so a tripartite relationship to try to get that, because we know AMR, one of the risks is agriculture and animals. But I think that's where I think one of the lessons is from this pandemic is how do we get those structures so we don't just think about what's happening in humans. We actually need to understand what's happening across the animal-human nexus, and that means regulating wet markets, looking at deforestation, looking at factory farming, like what we've seen in Denmark with the minks, looking at, and I'll end with this comment, we don't need to worry about bioweapon factories if we have places where we have animals crowded into cramped conditions and viruses are circulating within them. All the mutations are happening there, and all it takes is bad luck for it to jump over to a very badly paid, person who's working in that factory, who then will take it out to their crowded conditions, and then it takes off, as we've seen.
Thank you so much. Back to you, Vicky.
Thank you very much, both to Devi and Gabrielle, for your excellent presentations, and also for staying within the time limits. So we now go to the second part of this session, which is the member states' experience. Back to you, Frode.
Yeah, thank you again, and I'm pleased to be allowed to introduce my colleague from Sweden, Anders Tegnell. He's praised and criticized during the COVID response, as many of us who's been in the front line. So we are now going from the background papers and the background thinking to the frontline soldiers, from Sweden first and then to Italy. And Anders Tegnell, he is the Deputy Director General of the Public Health Agency of Sweden and a state epidemiologist. That's what they call it in Sweden. He's been in this position since 2013, and is a medical doctor with a public health training and background, and a public health a PhD in infectious diseases. Anders Tegnell has also worked internationally, for example, in Laos in 1990 to 93 with the WHO, and he was also active during the Ebola outbreak in 1995. So handing over to you, Anders, about the Swedish COVID-19 response.
Thank you. Let me see. It says here, take control. That sounds good. I'm going the wrong way. I'm trying to find my, here we go. Thanks a lot for inviting me to this session, and we heard a lot of background about the epidemic and so on from our previous speakers, so I'll try to skip through that fairly quickly and go into the experience from Sweden, trying to look into at least 3 different areas, which I think are going to be of interest to all of us. How did it start, especially in Sweden? And then I want to talk something about the contextual factors, which I think we need to think more about. And then I think that could challenge some of the, or many of the things we think have worked and not worked, because the contextual factors are so important for the spread of the disease this time, I think more than ever before. And then just to challenge all of us to go back to international collaboration in the end, because I think that's something that we could have done a lot more in that area. Let me start with maybe not talking about this slide specifically, but say a few words about herd immunity, because that came up at once. And I at once want to say that no, we are not trying to achieve herd immunity, because that gives the impression that we somehow let the spread of this disease go uncontrolled through the population, and I think that's going to be the winning concept. I think that was very early on already when we saw the pictures from Wuhan, and definitely when we saw the pictures from Italy, that was not a concept that was going to work. And I think we can all agree on that letting this just run through the population is going to cost far too much in many different ways. So I think the Swedish model was much more what you would call the number 2, as one of the previous speakers took up, and that we also tried to control it, but with slightly different measures that in many other places. And maybe thinking more about the contextual factors than maybe was included in some of the other measures put in place. The whole thing in Sweden started very much with the winter holidays. We have winter holidays in Sweden during February, and it's kind of a giant experiment, because those winter holidays takes place during different weeks in different parts of Sweden. And it was very clear that the Stockholm region, who had the winter holidays when the most of the spread took place in Europe, was the hardest hit. The south of Sweden had the holidays earlier on. It never really took off in the spring in the south of Sweden. We had the same measures all over Sweden, so that didn't make a difference. And in the north of Sweden, it was later on, and it never took off in the north of Sweden either. In both these places, it has taken off during the second wave we experience now. So I think that really shows that the introduction of this disease comes with travelers, and it comes in a massive scale. And we can go back and discuss if border measures could make any kind of difference to this in a modern nation where we have the amount of travel we have today, and if we really can make a difference with border measure. We did a lot of work early on, like many countries, in trying to control homecoming travelers from mainly the Alps, and in the beginning mainly the Italian Alps, because that's where the message came that most of the transmission took place. And I think also what we have done later on in genome sequencing shows that this was very successful. We actually stopped the transmission from the travelers from the Italian Alps. Those viruses disappeared from the Swedish population and has never returned. So that worked, but our problem was that this was not the only source during that time. We know that we have viruses that's coming from a lot of other European, North American nations coming in at the same time, and this more or less overwhelmed the Swedish system, especially in the Stockholm region and surrounding regions during early March. And we could not any longer keep up our testing and contact tracing procedures. So what happened, as you can see on this graph, we had a quick, not really quick, but rather quick increase. You need to understand that early on, the Swedish testing capacity was very limited. We tested around 20,000 cases a week early on, while we're now up in almost 200,000 cases a week where we are now. So of course you can't compare the levels of the staples in the beginning and in the end. But you can also see that the increase was rather gradual compared to many other countries. And we do believe that the sort of soft measures we put in place made it possible for us to hold it on a reasonable level, and our healthcare system managed to keep it in place. We always had free beds in our ICUs. There was always at least 20% extra capacity available in any given hospital in Sweden during that time. And I think that was part of the reason we never really need to restore to the harsher measures that was needed in other countries. Just to point out, the increase, which you can see in June, was not due to an increased amount of spread of the virus. It was due to that we managed to get more and more testing capacity into place. So actually, I think what you see is a gradual slowing of the spread all during the weeks up to the weeks 28, 29, when we were down at very low levels in Sweden. ICU cases, which are, I believe, a better indicator to follow the spread of the virus, because this is more stable and does not depend at all as much on how much you test. And here you can probably see the real difference between what happened in spring in Sweden and what is happening now during the last weeks. And the ICU capacity during this time in Sweden increased rather quickly, and since we managed to have the increase of the number of cases on a reasonable level, it managed to double its capacity in a number of weeks. So the system was never really overwhelmed, and as I said, there was always free beds. There was always at least 14% ICU beds free in Stockholm. In the country as a whole, it was even more. But in the end, each hospital actually managed to increase its ICU capacity, so we did not move very many patients. As you see, we had 3,000 cases in ICUs so far and 6,400 deaths. We'll come back to the death toll later, because that's been discussed a lot, and there is a lot to say about death toll as a measure of spread and the measure of success. So mortality in Sweden has been very high. More than half of it has taken place in the long-term care facilities in Sweden. These are not ordinary homes for the elderly. These are homes for about 0.7% of the Swedish population who are the oldest and the sickest. So this is really a small part of the population that really took the brunt of the mortality. And we can tell from almost any other country, and I'm sure my Italian colleague can say the same thing, when you get cases in these groups, I don't think we'll ever get any kind of healthcare or any kind of treatment that can really help them, because they get sick so quickly, and any kind of treatment you have in place will probably not save them. So this is something I think we all need to do a lot better, is to how we can protect this group of people, both in their homes, but hopefully we'll get a vaccine that can help them, even if that's going to be a tricky one. We had a ban on visiting nursing homes from the 1st of April to the 1st of October. We can say in retrospect that the usefulness of that was probably very limited. Now when we have contact tracing procedures and everything in place, we can see that it's very, very seldom that the disease is actually introduced through visitors. It's mainly introduced to staff, unfortunately. So there's a lot of context to talk about, and we could probably come back to this picture later on, because any kind of plan in any country needs to develop what they are doing very much based on context. And in Sweden, this was very much built on our previous pandemic plans. And as somebody mentioned, these are often based on the flu pandemics, and there are differences that we were not really so clear in the beginning, but are coming more and more clear over time. Another thing that's worth mentioning is that everybody seems to believe we have done nothing in Sweden, which is definitely not true. We did a lot of things, but we had more of a mixture of binding and non-binding recommendations than many other countries, because that's how public health works in Sweden. We could build on a lot of trust between the authorities, the political level, and the population. Even now, when we have a very difficult time in Sweden, we're still up at around 70–80% of the population that still trust the agency and the political level to do the right thing. We have all the time talked a lot about sustainable approach. As several of the previous speakers have talked about, this is going to be a long-term haul. We're not going to solve this very quickly. We might be able to solve it reasonably quickly if you're an island nation like Iceland or New Zealand, but for most of us, borders can never be closed that much that we can really solve it by ourselves. To do what we have done in Sweden, you need to realize you need to have a social security system in place like the one in Sweden, because if you tell people to stay home when they have the slightest symptoms, they need to be able to do that without any financial losses, and that's possible in Sweden. We definitely realize that that's not possible in all countries. Health equity, very important for us in Sweden. On the political level, that's one of the highest priorities we have. And unfortunately, once again, and nobody has really said that before, this has really hit different parts of the population very differently. And we need to take that into account into the future, I think. How do we protect our vulnerable groups better? And that's not only the elderly, it's also socioeconomic people with lesser socioeconomic abilities than most of us. And finally, like many countries, Sweden is very much a regional country when it comes to public health, and that has its own problems. I talked about trust. This is just to show you how big the trust has been between the population and the agency and the political level in Sweden. This shows how many people are answering yes when we ask them if they have adapted their daily life to reduce the spread of COVID-19. And as you can see, we have been on very high levels and basically been on very high levels for all different age groups. It fell a bit towards the end of the summer and during the early fall, but now when the pandemic is starting off again, we are going back up to higher levels again, which you can't see in this graph yet. And I think this can be shown by many countries, the enormous effect social distancing, mainly I think, have had on the spread of many diseases. This is just one example on the spread of pertussis in the Swedish population, how many cases we get into our system. And you can see that all previous years have a rather similar development, that we get more and more cases towards the fall when children come back to school and all of that, while during this pandemic season we have basically seen no cases at all of pertussis. Of course, to a certain extent it can be that fewer people come to healthcare and so on, but during July, August, and September, that was not the case in Sweden, so there's definitely some real effect also. And we can see the same thing on pneumococcal disease, we can see it on flu, we can see it on many diseases, how big effects. And I think this mainly shows that also in Sweden, social distancing was really in effect to a great extent. We talk a lot about how important it is to take a broad public health view on this pandemic, and I think one of the areas where we took that from the early on was to keep the schools open. We took that on scant evidence for sure, but we took it on very clear evidence on the bad effects of closing schools for children. And we have followed it during this pandemic, and we can still say that we can show very clearly that teachers are not worse affected than any other part of workers in the society. And children do get the disease, but they extremely rarely get seriously ill. And if the data about the teachers are correct, which we believe they are, they are not spreading the disease very much either. Of course, adaptations had to be taken in the schools to a certain extent. It's not easy to be completely social distance in school, we all know, but some things were done, and on the whole, it still works reasonably well. We have opened up the secondary high schools again, and there we see a fair amount of spread, which shows that there really is a gradient between the very young and a little bit older children that you need to take into account. But on the whole, you can keep schools open. So I'll leave you with these questions, and
thank
for the
you
next
very much.
speaker.
That's great. Thank you very much, Andreas. Anders, I mean, sorry. And you didn't have much time to see them, but there was one question here on the cross-border issue in Europe, and that we can come back to that afterwards in the chat, and also another one on the ways of coordinating actions towards vaccination across Europe. So you can pick up and think of that, and we're also lucky to have some questions that have been posed by the next speaker, Francesco Maraglino. So I'm happy to introduce you. He's the Director of the Unit for Prevention and Communicable Diseases in the Italian Ministry of Health. He's a Senior Medical Executive Officer and a specialist in epidemiology and healthcare statistics. He's also been representing and is representing Italy in many international settings and organizations. And most importantly here, he's a board member of ECDC. And we've met in several international meetings, and I'm happy to introduce now. You had a tough start with the pandemic in Italy, and we now hear from your response. And the question, we will come back to them afterwards. Thank you very much. And over to you, Francesco.
Thank you very much, Frode. I want first of all, thank you, escaide, the ECDC, the director of ECDC, the scientific committee of escaide, and Vicky and Frode in particular for inviting me in this very important conference. It's for me an honor and also a pleasure. I can see the slide, so I can take the command of the slide in this moment. But while maybe we can solve this technical problem, I can start to, yes, thank you, Moritz. As you know, Italy was the first country in Europe to detect global COVID-19 cases. And that's okay, thank you very much. I take the control now, okay. And but in Italy, the public health measures were immediately implemented from the beginning of the first signals and information that came from WHO and from China about this pneumonia of unknown origin, as it was called in the first messages from the international organization. We talk about I heard about the border measures, and the first measures that immediately at the very first days of January were taken in Italy was the border measures, because in Italy, as maybe you know, the point of entry health offices depend directly from the Ministry of Health, so are immediately ready to react to this kind of emergencies. The first measures that were put in place were a high-level committee, immediately chaired by the Ministry of Health, every day personally by the Ministry of Health, with all the stakeholders represented, the health stakeholders, and also the people from the regional level, because as I will explain, in Italy we have a decentralized health system. And the first measures were on health surveillance. We took the case definition from WHO and and also to laboratory capacity were immediately implemented. We designated a national reference laboratory that was in the National Institute of Public Health, and then the regions, according with the national laboratory, designated the regional, with the national laboratory, designated the regional reference laboratory, and so on in all the local health units. And then the reporting, because immediately we started with two reporting systems. One was a bulletin, a daily bulletin, very rough in some way, with information about new cases and in Italy, and that was on a daily basis communicated to all the public, also with TV and social media communications, and the epidemiological surveillance that was managed by the National Institute of Public Health, that collected all the information according to the case definition and laboratory definitions, and collected for tests and for the international epidemiological surveillance. Okay. This is a couple of specific epidemiological and organizational topics that we had in Italy. One I already mentioned was we have a national health care system. So the regional level is autonomy in the organization of the health systems and the health care systems. So in the chain of command between the national level and the operative levels, the local health services, there is this middle level that is really very important, because the management has to be of the crisis, but not only. Usually the health crisis is between the national and the regional system. And then this is something that is linked to something that also my colleague from Sweden said. We had the residents in long-term care facility were particularly affected, perhaps for the particular demographic situation in our country, because we have very elderly people, so these people were particularly vulnerable, and this is something on which we had to deal with. Another thing that was that I have to say, that when the WHO declared the fake, the Italian government decided to declare immediately a national health emergency, and so the chief of the Civil Protection Department was appointed to lead the response, because it was important to have a person who have good, very strong decisional power in some way. And the decision makers were supported by a technical scientific committee who was appointed in the civil protection, that included the officers from the national, from the civil protection, from the Ministry of Health, from all the other health agency in Italy, the National Institute of Public Health, and the scientists of different fields that were involved in this emergency, like pediatricians, like pneumologists, like intensive care representatives for intensive care specialists, and so on. Also, of course, epidemiology and infectious disease specialists, in a way, and the technical scientific committee convened every day to support with their advice, very quick, fast, and very good quality, every day in a very fast way to the decision maker on all the specific topics. Also, Italy had a whole of government response, because it was said that we have, it was important that in reaction to the first time, but also now to the emergency, we also other sectors were involved, not only health sectors, but for example, regional affairs, internal affairs, the Ministry of Education, and the ministers often took part of the meetings of the Technical Scientific Committee to have directly the advice on the specific topics that in which their ministers were involved. During this the days and the weeks, different public health measures were taken from the so-called red zones in Italy, so local areas in which there was a complete lockdown, to a national response, from the suspension of some specific activities to the complete lockdown. So this is the curve of the cases, and during these months, from January to last month, we have the timeline and the curve and the different measures that were taken during this period. At the beginning, we have the first public health measures, particularly on the border, in February, when we had the first outbreak in some regions of the north of Italy, and there was red zones were created in these specific areas. Meanwhile, then during March, beginning with March, we had more cases in different areas of the country, though in the north we had more cases, and so we went to the complete lockdown in all our countries. Then after April, and I will say in which way the situation was monitored, we have the first de-escalation measures, and for every activity that was reopened, there was a specific advice of the technical committee, scientific committee, with specific procedures, for example, for the workplaces and so on. During the summer months, we had few cases, and so we, of course, the holidays and travels started again, though in the internal point of view, but also with the external countries. And so when the half of August is the top of the holidays in Italy, we have a lot of people. So after that period, we have some enforced also on the Ministry of Health level of the contact tracing capacities, because the international one and the national contact tracing, not local contact tracing, is made by the Ministry of Health. And then we had the people came from the holidays, and some activities, the work, the school reopened, and so we observed during the following months, maybe as an effect of the more relaxed situation during the holiday, the curve rise again, and so Italy started again with the first re-escalation measures. Now, during these months, as I said, we had to deal with some important topics. The ICU and beds in medical wards, and so the creation of the COVID-19 hospitals, the continuous implementation of the laboratory capacity that I already mentioned, the validation of antigenic tests and the use of antigenic tests. That is an interesting topic. So we started to experience the antigenic test at the point of entry from people coming from some specific countries, and also at half of August for people coming from some of the regions in which the cases started raising, and also in the school setting were used at the beginning because it was really interesting and important for us to have a very fast awareness of the situation when some outbreak started in the school. But we'll talk about this also in the next minute. And then in this moment, what we are working on is the strengthening of the primary care health services by early detection and contact tracing, and so the passages from hospital to home care with involvement of the general practitioner, both in care and also in diagnosis with the use antigenic test. One important thing that I want to say, though I have not so many minutes, I'll try to go fast, was the combined action that was put in place with two important documents. One is a decree of monitoring for to monitor the possibility that in some areas the outbreak, the epidemic could be unmanageable, that was released at the end of April by our Ministry of Health, with 21 indicators that was indicators on the diagnostic indicators on monitoring capacity, on diagnostic and assessment and investigation and contact tracing, and to the resilience of the healthcare services. The first group was indicator of monitoring capacity. If the region hasn't a good monitoring capacity, the region is considered at high risk. And these indicators and the answers from the monitoring on a weekly basis of these indicators goes to a couple of algorithms. One is about probability and one about the impact of the probability that the epidemic in some area could be unmanageable, and the impact on the health, on the resilience of the health services. And so the combined answer in a matrix, in this matrix of the probability and the impact, realizes a risk assessment of a risk from the yellow is very low to the red one that is a very high risk in that regions. And so every week a special committee advise on this information the Ministry of Health. So on this risk assessment, which kind of action can put in place by the regional and national level? We have this document about preparedness or response on COVID-19 evolution, in which, according to the 8 pillars of the WHO, from national coordinator to clinical management to the point of entry measures to the national laboratories, every region is put in 4 scenarios. From scenario 1, local transmission, to scenario 4, uncontrolled transmission. And so these two information, the risk assessment and this scenario, is an advice for the regional and the national decision maker for put some regions in different areas of risk, so with the public health measures with different level, from specific activities to lockdown.
Can you try and conclude now?
Yes, I can
Francesco?
conclude. These are two important documents, one on laboratory tests and one on how to manage cases and outbreak in schools and kindergarten. And this is the challenge for the future, lower acceptance of public health issues, the same that we heard from the Sweden colleague, for the high socio-economic impact, but our government linked every measures, every restriction with a relief for some of the categories of the relief or their economical loss. And these are my questions. So I finished. Sorry, I'm Italian. I talk too much, but
no,
not
thank
so
you
much.
so much.
Thank you very much.
I think that's fine. So I think we can have those questions in mind. And I think there have come in some interesting questions on the chat as well. Have you been looking to that, Vicky?
Frode, I have been looking at the questions in the chat, and I see we can extend also more or less 10 minutes for the discussion if needed. We got permission from the boss there. So, okay, let's have a look at the questions in the chat. One question from Vasco Ricoca is, how did Sweden measure trust in the National Public Health Institute? And that's for you, Anders.
Thank you. Yeah, we didn't really measure it ourselves. There is something called the SOM Institute in Sweden who has this kind of questionnaires going out more or less continuously asking for trust between the population and different authorities. So the data I showed was part on that and also part from other questionnaires sending out by other authorities. We all realize that this is just what people are saying, but I mean, you can also at least say something about the stability of the curve, that it doesn't change very much. And I think the other part is really that people did change behaviors. I mean, we have many indications of that. We can follow and see how many people work from home. About 40% of the workforce works from home in the spring. As you said, we can also see that the spread of other diseases goes down. We can see the number of travels taking place when we look at mobile phone data. The Swedes lowered their travel as much as any of our neighboring countries. So there's a lot of indications of trust, even if measuring trust is a tricky thing to do. I completely agree.
Thank you very much. Maybe a question from the round table today. We follow the situation in Sweden very closely, of course, as you can imagine. We saw, and we also saw it in your slides, between week 30 and week 40 during the summer period, there was a period of low transmission in Sweden. How do you explain this? Is it the measures? It is a seasonal effect? Because the measures didn't really change in that period. So how would you explain that?
I think in my mind, this whole spread, there is forces that accelerate and there are forces that breaks. And these different forces are of different strength during different times. We believe that what happened during the summer was partly a summer effect because of the weather, being outside a lot more, having a lot less contacts that could be contagious, but also that Sweden, compared to many other countries, continue with the same measures in place over time. We never really sent the message that the problem is over. So, and I think the combination of those two made it possible for Sweden to have a lower transmission than almost any other European countries for a period during the summer. But I mean, it's a difficult disease to understand in that way. So exactly why we don't know, but it was definitely true because we kept on testing a lot during that time. I think our testing positivity was down below 1% for a while.
Thank you very much. I will continue with another question to you, and then I can ask the same question to you, Francesco. It's about the opening and closing of schools. Can you please share more insights of your experience with keeping schools up to 15 years old open? How many outbreaks did you see? Why do you consider the risk to teachers and educators low? So the schools.
Let's start with the last one because that's the easy one. We have a register in Sweden. We can actually look at people on the individual level and see what kind of profession they have. So we can compare the risk for different professions, the risk of getting ill enough to be able to have to go into hospital. And when we do that, we can see that teachers they have the same or lower level of risk than almost any other profession. Especially they have a lot lower level of risk than professions that need to be in their workplace, because of course there's a difference if you need to be in your workplace and if you don't. And that's also illustrated by the high school teachers had a very low level of risk during the spring when they all worked from home and didn't meet anybody. And during the fall when the risk went up because they went back to work. We had very few outbreaks in schools during the spring. We didn't test very much, I agree, but the outbreaks we had, a handful of them were mainly among teachers. Our interpretation is that most of the spread in the schools among teachers takes place among teachers in the coffee breaks and other things. It's not due to them meeting children, because there is also an interesting dose response curve that we can see that the lowest risk is among preschool teachers, and then it goes up until university teachers who have the highest risk. So there is, I think, very clear and interesting dose response in that way. So yeah, now we see a fair amount of outbreaks in high schools. Obviously, there is definitely this. It's not an on-off phenomena. It's a gradient among children. The younger the children are, the less sick they get, but also the less they spread the disease among themselves, and the older they get. And obviously, when you get up to high school, we have some fairly big outbreaks in some of the high schools. They don't get very ill, but they get sick enough to be noticeable. But it also, sometimes the schools then send a class or two home for a week or two, and then the whole thing stops. So it has not created any major problems.
Thank you very much. Francesco, could you elaborate on the Italian approach towards closing schools and any outbreaks in school settings?
Yes, thank you very much for giving me the opportunity to talk about school, because it has been a very important topic in our country, of course, like in other countries, because of course education is crucial. It is considered crucial for not for the children, but also for the families, because if the children stay at home, in particular under the same age, so one age is one certain age, of course we have issues also for the family, for fathers and for mothers and so on. And so the approach was to have a very clear and very specific procedures, preventive procedures for the reopening of the school. So there was an agreement between the health ward and the school ward, also the union trades of the schools, on the measure to take place in the schools, very precise, approved and by the scientific technical committee. The same with the document that I showed very briefly before. There was a document in which all the scenarios of the possible outbreaks were in some way pictured, and in these scenarios were very well written what were the public health measures and all the kind of actions that both school and local public health authorities had to put in place. And we tried to make closer the school of the ward and the public health school at the local level. That was not or in the ordinary ward in Italy. So of course the recommendation about masks, about hygiene, about social distancing were given, and the school manager of course implemented that in every way. So in some way the school is like some working place, or all the working place in which there are preventive measures very well and precisely designed and respected, was not a place in which the outbreak were too much. We also observed very few outbreaks. The National Public Health Institute is studying this in the school. In particular, the issues were mainly in what happened before and after school, because of course outside of this very protected environment like school and other protected environment, of course not always the compliance to the three pillars of the prevention are the same. And then another very important things on which we are discussing about is the impact of the reopening of school while reopening also working place and so on with the public transport, because while the little children went to school in their area or their district usually, and with their parents or grandfather parents that put them to the school, young people are independent, so use the public transport, and so it's not easy to in some way to reduce the number of people in the public transportation and so on.
Okay, thank you, Francesco. I'm jumping in to tell everybody that we have the whole panel available here for you for another 5 minutes or so. So if there are questions to some of the others as well, I think that could be fine. I have a question that had just come in about the situation connected to this question of compensation from work. Which role does that play when it comes to really keeping people out of being at work when you have symptoms? It might be good to have a comment from Scotland and one from Sweden on that. Anders first.
Okay, no, I think it's really important, because some of the people that are worst affected are people with less economic resources. So that's very important to make it possible for them to stay at home. And it's also many of the people working in the long-term care facilities are also in that group. And once again, that's a group of people that we really want them to stay at home and have the best possibility for them to actually stay at home. So I think that was a really important measure that the government put in place. Previously, you had the first day you stayed at home, you didn't get compensated, but from the second day you got compensated. Now you get compensated from the first day. It might sound like a small difference for some of us, but for many of these people, it was a really big thing. So I think it was really important.
Thank you. How is it in Scotland, Devi?
Yeah, so actually isolation payments aren't great, to be honest. So you actually lose money if you don't go to work. And so you penalize people for their goodwill of actually staying home and not infecting others. But we have been trying experiments. So for example, there was a factory outbreak and they were finding that they wanted everyone working in the factory to isolate and compliance was low. So they reached an agreement between the government and the factory that people who isolated for 14 days would get their full wages. So their job was to stay home. But if they broke isolation, they would lose it. And actually compliance went up to 100%. So I think it comes back to kind of, financially pay people for an act of goodwill. Emotionally, what do they need? Is it phone calls? Is it care packages, essential goods? What do they need? And third, I know New York City has been very successful in offering hotel rooms and managed isolation outside the home to try to break, especially in crowded flats, getting out. So those are things. And I wanted to also just come back that when I put the Sweden model up, I put it like this because I don't think it was actually Sweden's model, but I think unfortunately the way President Donald Trump saw it, the way that in Britain it was discussed, it became the view of this is how it was depicted, though actually it was much more complex and thoughtful, as Anders has said, in the way it was portrayed to right-wing parties of different countries.
I'm happy you're not taking Trump as the truth sayer in this.
Okay, a couple of more questions from you, Vicky, before we end off.
Yeah, maybe one question that was put in the chat as well as on the long-term care facilities. The two countries have different approaches, but both had major issues in long-term care facilities. I would like to hear your views on the approaches there.
Since I'm the quickest talker, let me start.
There was a specific question for you, so you can answer if you would like to.
Okay. No, I think you need to realize that long-term care facilities are complicated places. There are so many different things involved, and I think the most dangerous thing you can do is to think that if you just provide them with more protective equipment, the whole thing is solved. So what we really try to do is to look at it in a broad perspective, we together with other agencies. And so there was a broad program put in place. There was an intensive training program for the people working there, with distance training for all of them. Better protective equipment were put in place. The incentive to stay home when you had symptoms were put in place. We also increased access to testing a lot in those groups. We also saw to it that they had isolation possibilities for the people living there if they got sick. So what we did was we put a whole package in place in those many of those, and I think that's really what you need to do. You cannot really solve it by doing one thing. You need to do a whole list of different things to get it to work well.
Thank you very much. Francesco, you want to elaborate on this?
Yes. Of course, we deal with issues about long-term facilities and people who was there, and then we also, of course, implemented the use of personal protective equipment. Of course, the monitoring of symptoms for people working there, and in particular, the responsibility was raised about to stay at home if they have also mild symptoms. So it's very, very important. And also the testing from the very beginning of this topic, the testing capacity, the testing indications for the test for people working there was implemented. It was one of the first priority also in the moments in which the testing capacity was lower than this one. And a very important thing, a very important issue is the one of the isolation of people living there, as my colleague from Sweden also said. And we are working on this, again on this topic also in these days, and we are producing also a technical document also on these topics, because of course it's really important that the people that they live there don't feel themselves isolated from their families.
Very much. We have an interesting question there on long COVID, but I see Martin appearing, so it means probably that we have to wrap up. Do we have time for one more, Martin, or do we wrap up? One? Okay. So the question is, do we have enough focus on long COVID? How are you integrating this condition into surveillance and research strategies in your countries? Long COVID, but short answer.
Okay, very short answer from me. No, we are not doing surveillance on this. What we have done, or what the hospital system has done, is to put a program in place for evaluation and treatment, or whatever, management is better, maybe a better word for this group. It's a very complicated group, I think. I'm sure it's gonna, it's comparable to chronic fatigue syndrome and many other similar syndromes we have in place, even if the background is different. And we know that those symptoms are very difficult to deal with. So what we have done so far in Sweden is we have put a program for the management of this group in place. And there is a quality system being put in place to follow that, but nothing else so far.
Thank you very much. Any of the other speakers would like to say something on this?
Yes, very, very briefly. Also, this is a topic on which we are working also in these days, and I think that in particular the best thing we can do in a general way on this kind of topics is to balance what are the specific role of the hospital and what is the specific role of territorial, as we know, healthcare, in a way to balance the care of different groups in the different settings, in a way in which all the health fields collaborates in the more appropriate way. I don't know if I've answered the question.
Thank you. Thank you so much.
Thank you very much. Frode, you want to do the thank you and goodbyes?
Thank you and goodbye. I think that was a great session. Thank you very much to all the speakers for sticking to time and giving us a lot of very, very strong and valuable insights. And I think let the discussion continue where you are, and also stay in touch. I think we have to, let's say, stay together and stay apart, but stay tuned also for the rest of the escaide conference. So thanks a lot to everybody, and over to you, Martin.